some things that I want you to take a look at here, and I wish I had a little bit of a bigger screen to see, but this is an 8-year-old who is starting to lose their baby teeth and growing their adult teeth. They're in something called mixed dentition, meaning that they have some adult teeth and they have some baby teeth. The baby teeth are the 3 teeth here in the middle. Actually, it's the 4 teeth. So 1, 2, 3, 4 on the top, okay? Specifically, if you look at these 2 teeth and this one right here, can you notice how flat that tooth is? This is an 8-year-old that has a baby canine, and it is as flat as a plateau. This is the type of grinding evidence that we see in somebody that's been grinding their teeth for decades. And we see so many children where they have, if you look at this kid's smile, this is their front teeth. They're stacked up on top of each other. We're seeing the evidence of crowding already. With our adult children, with our children, you see these other adult teeth coming in. They're finding room to come in. So this is something that's standard that Dr. Patel and I see every day with our children, where all of this crowding, all of this wear on teeth, and why do we continue to see this? This begs the question. Most of the time, we just chalk it up to that's how kids are, or it's something genetic, that's just how my kids are. I needed braces, I didn't have room for my wisdom teeth, and so as things go underdeveloped, and we continue to grow, you can go on to the next slide, we have something like an adult here. So this is another very common type of presentation that we see with our patients. This is a 49-year-old. One thing I want you to see is how much dental work this person has done. So outside of maybe these bottom teeth from here to here, every single tooth in that mouth is a crown. This person had 11 root canals over the course of his life. If you look, his mouth is all the way closed. His mouth is not open. You see the opening there. That's what we call an open bite. One of the other things too, which hopefully you all can appreciate here, but if we look at the canine tooth, so the canine tooth is the long, sharp one there. Do you notice that at that point, the mouth seems to kind of make this sharp turn and curve and go straight back? It doesn't have that beautiful architecture that we like to see where we have that half circle arch. This, believe it or not, is how most of us are. I would bet outside of the open bite, but that small, narrow jaw, most of us present in this way. Let me go to the next slide. One easy way for us to tell, figure out what's going on here with these small mouths, what fits inside our small mouth? Our tongue. And so if we don't have the right size box for our tongue to sit in, we're going to have issues. So go on to the next one. An easy way for us as dentists to tell if somebody has the right size mouth is, I don't know if you guys have been to the office or been to an office and ever seen these little cotton rolls. So these cotton rolls are about 38 millimeters in length. And so everybody should be able to stick one of those right in between their molars with room to spare. And this is that same gentleman. You can see how the cotton roll looks a little scrunched, and there's just not enough room. Where's the tongue supposed to go in that situation? Next, please. So how does this all start? Once again, with our children. To go through how much sleep apnea is an epidemic with it, it starts in development. We look at these beautiful shining faces here, okay? And it's so easy to be distracted by our beautiful children that we don't see the obvious signs of sleep apnea. Let's start with this child here in the blue. Do you see the dark bags under his eyes? He looks tired. We look at the girl over here on the right. So she has that gummy smile, but she has something that we call a deep overbite. And if you also look at her chin, look how small and narrow her chin is. Her lower jaw is underdeveloped. If we look at the beautiful girl at the top in the pink, if you look at her front teeth, they're sticking out forward. So she has a small upper jaw. Same with the girl right next to her in the back. If you look at her front teeth, she's suffering from the same thing, small, narrow jaw. The boy over here in the back, dark circles underneath his eyes. This isn't a photo that I just was looking for dental stuff. This is actually a photo that somebody pulled for some type of fundraising, for children. And so they're just showing children for an educational thing. And I pulled this up, and you just see the obvious signs of dental disease that's there. And you can go on to the next one. I pulled up another picture. And as you start looking a little bit more closely, it's really difficult to look at children today and not see the signs that they're tired, these small, narrow jaws, not room for the developing teeth, where you see this girl over here or this one here where the teeth, they're just not coming into the right place. By the time we're 12 years old, our head is fully developed, so it's too late. We need to intervene before then, and so it begs the question, why is this happening in the first place? Can we go to the next slide? So once again, this is stuff Dr. Patel and we see every day. This is how our children look. So where does this come from? There is an anthropologist. His name, I always butcher it because it's Italian over there. It's Dr. Corrigini, I think that's his name. He's an anthropologist out in California, and he studied, since 400 years ago, the shrinkage of the human skull. And so he, I believe, where was he working? It was somewhere in Europe where he was doing his studies. And he just documented that over the course of 400 years, our mouths are getting smaller and smaller and smaller. And so come to find out, why is this the case? Now, the area that he was looking at these skulls was in a developed European country. Go ahead to the next slide. But when he started discovering skulls of indigenous cultures, so places that didn't have the influence of Western societies, he noticed these people that have absence of dental disease. They don't need their wisdom teeth pulled. They're having these straight teeth with the perfect architecture. It's, the need for orthodontists, it's not even needed there. These people didn't have access to dental care, and you see these beautiful straight teeth. Come to find out, he believed that the underdevelopment of the jaws was not something that was genetic, as we previously thought. He believes that it is due to the influences of Western society, and I'll tell you what I mean in just a minute. This is a modern picture today. And you see these children never had access to a dentist in their life, and you look at the difference in these children versus the ones that I showed you before, okay? This, by meaning that malocclusion is the teeth not coming together in the correct way. That's what malocclusion means. It's acquired by the foods that our children are eating. Now, go ahead to the next slide. Our children in Western society are eating foods that are so easy to digest. They're processed. As soon as it hits their lips, the food just dissolves. So they don't need to develop the muscles of the face. I'm sure, as you guys know, with this facility here, you're working on your muscle tone. It's, you're trying to build your bone strength and bone density as well. Muscle tone follows bone growth and development. So as our children are growing and they don't need to work for their food, they're not developing the muscles of the face. During those critical years up until they're 12 years old, if they're not developing the muscles of their face, their bones are not growing. So instead of eating apples and the sweet potatoes and the things I put there, we're turning things into mush, and we're having our children eat those. There is an aversion to kids swallowing certain foods, and we've seen those videos of where people take babies and throw them into the pool and they're fine. They just naturally have this instinct to know how to swim or how to breathe underwater. We're a little bit too careful with some of our children on the foods. We're, as a society, afraid of them swallowing certain foods, so we want things to be very easy to digest. And granted, yes, there are certain things that children need to work themselves up to. I'm not saying to give a newborn, a whole apple there necessarily, but you get the point that I'm trying to pull across. A lot of the foods today, children don't have to work hard. Also, if we think of breastfeeding, as a society, we frown on breastfeeding of children of a certain age. And a lot of these third world countries, they're breastfeeding their children to 4 to 5 years old. And there's something much different than nipple from a bottle, where they just wrap their lips around it, and it's just gravity, basically. All they have to do is just lean back and the liquid just drips, versus them having to suck and really develop the muscles of their face. Okay, next slide, please. So, what's happening, we're gonna start with this picture over here on the right, forgive the small view of it, but what you're seeing here is on the right, this is that picture, this is the tongue. And so this is if you're looking at somebody straight on, and we've subtracted their face. So we're just looking at the width of the tongue. So what's happening here is on the right, that's how it should be. The tongue should be wide enough, the mouth should be wide enough for the tongue to sit up on the roof of the mouth. And with doing so, the tongue moves up and forward away from our airway. And so if our tongue is too narrow, we have that cathedral-like ceiling over there. It's more work for our tongue to rise to the roof of our mouth and fit and suction as it should. So what ends up happening is we have something called low tongue posture that happens with our kiddos. Their tongue is not able to fit up on that cathedral ceiling. All right, with doing so, then they have to resort to mouth breathing, because of that. If your tongue's not able to set up to the roof of your mouth when you close, then the tongue falls back down to the back of your throat. And in order to breathe, you need to create room. So you open and breathe this way. What's dangerous about that is a couple of things. One, with the mouth breathing, it sucks in our jaws and makes our mouth even more narrow. Two, we're bypassing nasal breathing. And there's so many very, very important things about nasal breathing. First of all, we all got these little nose hairs. The nose hairs filter out just basic dust and pollen. And so it's a natural filter as a first line of defense of the air we're breathing. Two, there's special mucus cells that also help to filter our air. And there's also some cells that exchange and infuse our air with something called nitric oxide. Nitric oxide is a natural vasodilator. Vasodilators are very, very good things for what? For blood pressure. If you're not breathing through your nose, you're not having your body's natural blood pressure medication. So that makes us more stressed. It puts more work on our heart. And then we're missing those. The last thing, sorry, about nitric oxide is it does kill bacteria. So we're having all of these antibacterial agents that we're not going through our nose, and we're going straight through the back of the mouth. Why is that dangerous? How many children do we know need tonsil and adenoid surgery? Their first line of defense now, instead of being their nose, is the back of their throat, which is meant to be a tertiary line of defense, not the first. There are so many children that we are able to help avoid tonsil and adenoid surgery by just helping them breathe correctly. And with that, you think about the stress. You think about those children that I showed you before with the bags underneath their eyes. I think I'm jumping ahead of myself in the presentation a little bit, but there is so much ADHD out there when really, there was a study that, I can't reference it, so forgive me, but there was a doctor that looked at the symptoms of children presenting with sleep apnea and ADHD. And long story short, clinically you couldn't tell the differences apart. You really couldn't. And so then when you're taking your kids to the pediatrician and they say you have ADHD, how much confidence do you really have? There's a lot of children out there being medicated for ADHD that just aren't sleeping well. Next picture, please. So this is an X-ray of how these underdeveloped jaws are leading to closure of the airways. Red is very bad, blue is the size that we need it to be, and in all of these situations, we have people that are breathing out of a coffee straw versus a garden hose. Next slide, please. So I don't know if we have audio on this, but this is a video taken by a nurse who her child was suffering from sleep apnea. She's trying to figure out what's going on, but this child was no more than 2 years old. I don't know if there's some audio here. It's about a 2-minute video.
Okay, this is a picture of Eli holding his breath. Right now he's snoring. We're going to see what happens. This is February 6, 2009. There he goes. See that? He shakes. He's kind of woke himself up. Okay, now let's listen again. Quiet. In a few seconds he'll probably hold his breath again. You can hear him snoring. And he's breathing through his mouth, not through his nose. And he's not congested now. He doesn't. There he goes, I think. There he goes. Saw that? Now he's gasping for air. The breath he took beforehand, he was actually not getting anything into his lungs. Now again, he's only kind of... He's not really getting anything in right now. Now he's going to take a deep gasp in a few seconds. There he goes. And again, he's going to hold it now. There goes a deep breath again. That was a clear breath. And now again, he's going to start holding it. All of these breaths that he's taking right now, he's not really getting much into his lungs. There he goes. Now every time he shakes like that, he's essentially disrupted his sleep. Now he's holding it. That was holding it. He's still holding it. He's trying to take in air. There he goes. Okay, now watch. He's holding it. He's holding it. He's holding it. He's holding it. He's still holding his breath, and now he's going to gulp again. There he goes. That was it again. And again. He's holding. He's holding. He's trying. There he goes. So this has been 3 minutes and 15 seconds, and you can see how many episodes he's had of not getting calm breaths in. Now, watch what happens when I take his jaw and I just bring it forward. If I can. Let's see if I can. And I open his airway. Just bringing his airway forward. Now listen to the quiet breathing. There we go. Now he's breathing through his nose. And I brought his airway. I'm opening his airway. Just pulling his jaw forward ever so slightly. And now he's breathing through his nose quietly. His mouth is a little bit open, but he's breathing through his nose. Just by hear how quietly he's breathing, you don't hear him anymore. And all I did is gently bring his jaw forward. That's it. Essentially allowing the air to go in through the nose and clearly down into the trachea. tonsils aren't blocking anymore. I'm going to let go. Let's see what happens. Now he's in a comfortable position. The jaw is still forward a little bit.
This child, he's just sleeping in his car, in his child seat, and you notice him gargling his spit, his tongue, these long, dramatic pauses where he's not breathing. And what this nurse did is, so she would watch and count, and it's like a 4-minute video, and with it you look at how many apneic episodes this boy that's less than 2 years old is having. And all she did to help correct this, you hear how audible his breathing is. She puts her finger in his mouth, grabs his lower jaw, and pulls it forward. And all of a sudden, everything goes silent. You don't hear the breathing, you don't hear the liquid in his throat, and he's just breathing so peacefully. And it's really powerful to see just this child's jaw is underdeveloped. He has a double chin. He's 2 years old with a double chin. I mentioned ADHD already, okay? And so if our children are tired and not sleeping well, yes, they're gonna be cranky, they're going to be irritable, and we can only imagine what this does just to their social development as well. And you get that call, from as parents getting that call about your child and say, Johnny's acting up, he's being disruptive, and it's really heartbreaking. Even this child, you can see the bags underneath his eyes. Next picture. The other thing is bedwetting. So bedwetting is not something that is as talked about. And so it's one of those things that what parent wants to broadcast to the world that their child is wetting the bed all the time? It's happening a lot more than we think. What's happening is when you have an apneic event, you stop breathing, so your body goes into fight or flight mode. So your heart rate starts to pound. Our kidneys work via a filtration system. The more liquid that gets filtered through our kidneys, the faster our bladder fills up. So these children that are wetting the bed, they're basically not breathing throughout the night, going through these fight or flight episodes, and their heart is racing out of control while they're sleeping. And with doing so, their bladder fills up quick. Also, with the fight or flight response, bladder control is not something that takes precedent on that. So the body diverts attention away from the muscles to hold the bladder, and they void themselves. There's a study that with proper treatment and just getting children to breathe correctly, I believe there was like a 95% resolution in this sample of thousands of children in bedwetting in less than 2 weeks. Next there. So how can the dentist help? Well, in our children, prevention is key. So it's a lot difficult to more manage the adults, which I'll get to in a moment. But with children, there is an appliance called a tooth pillow, and this is it. This basic, simple appliance, what it does is, you can see, first of all, on the picture on the right, do you see how there's a little flipper at the top? So that flipper, it bothers the kids' tongues. They don't like it, and they play with it. What is that doing? So remember I talked about low tongue posture. This encourages high tongue posture because they go and play with it all the time. That helps them to train their tongue to sit up on the roof of the mouth while they're developing. As their tongue sits up on the roof of the mouth while they're developing, they push the teeth out. And so then we don't have that narrow dental arch. The second thing that it does is it's a mouthpiece that on the bottom, it pulls their lower jaw forward. So as I wish you would have seen in that video with the nurse that grabs her child and pulls the lower jaw forward, this is a device that holds the children in that position all night. The third thing that it does is, I wish I would have shown a picture of it, but when the children put this in their mouth, they can't close their mouth. Their lips literally can't come together. And you feel the lips, you feel their chin, all of the muscles, they are so tight because their mouths aren't trained to grow and develop. They don't have the musculature to be able to close. And so this is stretching those muscles to help them to close. The more elasticity that they have on their mouth, the more they're able to close their lips when they sleep and nasal breathe, okay? This simple appliance, they wear it during any stages of development. We start as early as 2 years old. As soon as children have teeth, it is something that they can wear. We have sizes for infants, for toddlers, for teenagers. There's different ones, and children love this thing. There's so many benefits of that, and a lot of kids, once they have their tooth pillow, they just have a hard time sleeping without it. Next slide, please. So, as far as our children, prevention is key. That simple appliance, there is, and with a limited amount of time that we have, I don't want to simplify the kids to say, hey, just wear that pillow and that's it. There are some other things to it. First of all, they need to do, if that tooth pillow didn't help them grow to their full potential, one, it is going to help them with their sleeping immediately, and it's going to help them avoid a more complicated orthodontic procedures later on, but ortho tends to be very, very straightforward and predictable for the kids after that. Two, they might need some physical therapy to help them breathe. And if there's other things going on as well, or we're seeing like they're having trouble losing weight, or any kind of medical complications going on, of course we would work in their pediatrician and work with that. But the point I wanted to drive home with the children is identification. I wanted you all to see our children and look at these small little jaws, these crowded teeth, the bags underneath their eyes, the behavior, the bedwetting, and just be able to see it for yourself. And if you start to look at that, you'll see that it's everywhere. I can't even, I don't know if you guys seen Little Rascals over there, but yeah, I can't even watch that movie anymore without looking at all the kids. I'm like, oh man, it's everywhere. As far as the adults, sleep study technology has come a long way. And so once we're older, that right now your options are, you take a sleep study, go to your sleep physician, and they say a couple of things. They say, well, you probably need something called a CPAP. And everybody knows about the CPAP. All right, so what is a CPAP? Mask that, there's different versions of it, but a mask that goes over our face that forces oxygen down out of the back of our throat, so that way we can breathe better, have better oxygen exchange, and tries to stop some of those apneic events that we have. But is a sleep apnea treatment? I challenge you to think about that. Is it treatment or is it management, much like medications are? We're not making people truly better with a CPAP alone. There is research that says that a CPAP will help with facilitating a remodeling of the airway and making so that your esophagus and your throat is wider, so that way you can breathe a little bit better. But at the end of the day, if we're having all of these smaller underdeveloped jaws and we're having obstructive sleep apnea, it will come back. And compliance with CPAP, most people only wear it for maybe 4 hours out of the night. The other 4 hours, you're still having your apneic events. So the root cause of sleep apnea is these underdeveloped jaws, and that's where it begins at the dentist. We see this every day, and there is now ways for adults to make their mouths bigger, and that is truly treatment, to correct the root of the problem so that way we are not having those apneic events and not being dependent on medications, not being dependent on an appliance or device for the rest of your life, so be able to breathe accurately. One of the other popular sleep apnea treatments that medicine provides is something called Inspire. I don't know if anybody, raise of hand, has anybody heard of Inspire before? So it's an electrode that they install in your chest, and when you have an apneic event, It shocks your tongue to force it out of your mouth, so that way then you don't breathe. Is that treatment, or is it management? I lean on the side of management. A third option that they will give you is orthodontic surgery. Now, that I believe is treatment. It's an aggressive treatment, but basically what they do is they realize what we've been saying is that your mouth is too small. So then they go and would have to do this surgery. It's called a Lefort surgery, where they break your jaw. Then they put your mouth in the position where it should be, wire you shut for a couple of months, and then, hey, we're at the desired route that we want to go to. I don't know about you, but I can't go without talking for 3 months. And I wouldn't want to go through that. That sounds rather aggressive, and most people wouldn't, and most people don't. It's probably the least used sleep apnea treatment out there. People don't want to go that route. What can the dentist do? So in terms of getting a sleep test, before you had to go into a sleep center in order to be tested, technology has come so far. And so in our office, we use these called the sleep image rings. Sleep image rings have this amazing new technology called cardiopulmonary coupling. Now, cardio, heart, pulmonary, respiratory system, and couples. So it bridges the relationship between the heart and our lungs in terms of how well our body is responding to how we sleep. The other type, do we remember? I'm trying to remember what.
PSG study?
Yeah.
That's your in-lab is a PSG study.
Yes.
And they put electrodes on your head, or sensors really, and they're monitoring the brain waves. So the cardiopulmonary coupling is one way to do it. It's more of an internal method as opposed to the external method of the PSG study.
And then traditional sleep tests, there was, polysomnography. That's what I was looking for. So most sleep test technology uses something called polysomnography, which it is a older technology. And what that technology does is it measures how well we breathe, but it focuses on just the apnea and how well our body is exchanging oxygen, but it's ignoring how the heart is related in all of this. And as I mentioned, sleep apnea is related to the top 20 diseases in the United States. There is definitely a heart component to sleep apnea, with the fight or flight responses kicking in, increasing blood pressure, making it hard for us to have proper metabolism. So this data is extremely accurate, and it's something that you just put on your finger, and we are able to get, in some ways, more comprehensive results in how you sleep. We're able to interpret this and decide, figure out if we do have sleep apnea. If you do have sleep apnea, what we need to do is make your jaws bigger. Now, I mentioned the surgical expansion. This is the non-surgical expansion. This is something called a Vivos appliance. It's a mouthpiece that you wear. And you see how many springs that thing has? It has springs all over the place. This is a removable appliance that comes in and out. You wear it while you sleep, and you wear it for a couple of hours during the day. This appliance is meant to come in and out of your mouth. And so with that, it's pushing and relaxing, pushing and relaxing, pushing and relaxing. What does that look like I'm doing? Exercising, right? So we're working out the jaw, pushing the bone, and facilitating expansion. It was once thought that once when we were kids and those growth plates in our mouths fused, that we were done growing. There's been countless research that's shown that those growth plates can be re-stimulated up until we're 80 years old. So there is plenty of time for people to grow and develop to their full potential. And the patented technology in this device helps to slowly reactivate the stem cells in our growth plates and actually generate bone growth.
It's expensive.
Yes, it is. But at the same time, how expensive are those medications that we're on? How expensive is it the loss of life that we had? And those CPAPs as well too. It really is. When I'm having this conversation, and I'm glad you brought up that point there, Knowing why we're doing this in the first place is very important. There's 3 things that I talk to people about with if you have sleep apnea where it affects you. It affects your cardiovascular health, okay? We know what that means. Blood pressure, heart troubles, stroke, AFib, you name it. It affects our brain health. If you're not getting accurate sleep throughout the night, what happens is certain plaques in our brain build up called beta amyloid plaques. I don't know if you've heard of beta amyloid plaques before. It's a buzzword related to Alzheimer's. When we sleep, you're supposed to get a certain amount of deep sleep uninterrupted throughout the night. And if you don't, those plaques build up in our brain and it increases the chances of us having neurological disorders, Parkinson's, Alzheimer's, dementia, poor memory loss. So I tell my patients, well, do you want to remember your grandkids? Do you want to preserve those memories? Third is your metabolic health. If you're going through fight or flight response while you're sleeping, what's happening is your heart's pounding quick and your body is pumped with stress hormones. One of those stress hormones is a hormone called cortisol. Okay, if you look it up, cortisol correlates with insulin. When your stress goes up, your body is preparing for a famine. So it stores up as much fat as possible so that way you have energy for whatever trauma that your body thinks it's going to endure. So if you're having sleep apnea, you're gaining weight in your sleep. Why do we have so much prevalence of diabetes? This sleep apnea epidemic is related to so many things. And so really figuring out what are we trying to attack here? How are we trying to make your life healthier? There's so many components from the medical side of things, not to mention, you saw that gentleman in the first bit with all of the crowns, all of the root canals. The man didn't have a cavity in his mouth. He's just breaking his teeth left and right. And he told me that he had spent over $100,000 in dental work in his life. And then he showed up to me for another root canal and another crown. It's like, how do I stop this? I'm just ready to pull out all my teeth. So sorry to go on that tangent there, but at the same time, it's something we're very passionate about. We're seeing this all the time, and we want to find the value in getting people over the sleep apnea hump. So this is one way. After we expand the teeth, right, you can imagine I'm flaring out, what happens to the front teeth? Well, you do have some gaps in between the teeth. So we have to get you in some Invisalign, close those gaps, all right, so that way we can get the proper smile that you have. But it's a 2-step process from wearing the appliance to expand. That appliance, you wear it for anywhere from a year to a year and a half. And then afterwards, then we wear the appliance. So it ends up being a 2 to a 2.5 year process to be able to help you grow to your full potential. Next slide, please. The final thing is laser therapy. So as we're snoring, what's happening to the back of our throat? It's vibrating, and it's vibrating rather violently. What is that doing to the back of our throat? Causing inflammation, chronic inflammation. And when something gets stretched over and over and over again, it gets flabby. So we have this flabby tissue. If a lot of us look in the back of our throats, we see how low our tonsils are hanging down, how low our soft palate is hanging down. And when we lean back, that soft tissue falls in the back of our throat. It's not as tight as it used to be when we were younger. And that soft tissue is what we're struggling with while we're having apneic episodes. This laser, it's able to zap the back of the throat. It's a painless procedure that tightens up it forms collagen in the back of our throat and tightens everything up. And it's a way for us to instantly improve the way that you sleep. Now, this doesn't last forever. This alone only lasts for maybe 6 months because we still have all of the underlying malocclusion and the small mouth here. But with the trio of those 3 things, we are able to manage sleep apnea. Is it the dentistry show all in of itself? No, it's not. Okay, but if our mouths are too small and we're not starting there, the medical doctors aren't even looking at your mouth. They're giving you a sleep test, they're saying you have sleep apnea, and they're saying, here's your CPAP. And it should all start at the dentist, making sure that you grow to your full potential. We need to get all of our kids evaluated and making sure they're growing to their full potential to make sure that we eliminate all of this nonsensical disease that our children are going through. And then as adults, maybe we wouldn't need to have so much of this treatment if we all grew to our full potential. But that concludes, I think there's, if you go one more, I think, yeah, so this is it. So this is the results of the laser treatment. This is after one application of the laser. So if we're looking here, we look at something, there's a classification of how open your throat is called a Mallampati score. And so if you open and you can't see your uvula in the back of your throat at all, that's the worst situation. And so that's how you can tell if somebody has a low palate. You just open up. You don't say ah or anything, you just open and you see how much you can see back there. Most of us are like this. Within one treatment, now you can see all the way to the back of his throat. And so all of that tissue rose up. It's less loose and flaccid there. And so, that's another way to manage that. But thank you so much for your time. At our office, we do free sleep evaluations on all of our children. We're really passionate about the kids because the treatment is so simple. We don't have to go through the laser and the wearing the appliance, in and out and all of that stuff. For children, it's so simple. Just getting them identified, getting it early, and making sure that during those critical stages, that they have the proper help that they need. And then, we do sleep tests on adults over there. And then, Dr. Patel, I can't remember if there's anything else I'm missing, but.
No, I was just going to throw in, you said 1, 2, and 3. I would argue that there is a fourth component of myofunctional therapy.
Please.
So, the last bit of when we're treating adults, I really advocate for myofunctional therapy. So we're in a gym right now. We know that exercising is important. Like Dr. Lundy was saying, working out those muscles is important. It's important in adults as well. So we still want you to gain the musculature that you're supposed to have in the mouth and get that tongue posture from having that low tongue posture to being up and the roof of the mouth. So I advocate for it for kids, but I also really love when my adult patients do it as well because I see really good results.